Hello everyone, welcome to the 5 Minutes More series. My name is Mohsen Salim. Today we will be going over peptic ulcer disease. First of all, let's discuss what an ulcer actually is. So ulcer is a sore or break in the intestinal mucosa, usually in the stomach or more commonly in the duodenum. So how does it form? The pathogenesis is really based on two factors. If there's an increase in gastric acid or a decrease in mucosal protection. So if there is this sort of imbalance, that is what is causing the ulcer itself. These obviously have a lot of contributing factors, so let's just look at those very quickly. So prostaglandins and bicarbonate, those are big factors of the mucosal layer that stops the hydrochloric acid from actually getting in contact with the stomach mucosa, so it doesn't burn through it because the acid you have in your stomach is very strong. Blood flow is of course important because without that, not much happens. If we look to the bad contributing factors, so I got men tangs to do. Men multiple endocrine neoplasia. This is related to Zollinger-Ellison syndrome, which is a precancerous condition sort of that forms tumors mainly in three places. Remember that as the three P's. So you can form it in the parathyroid, the pituitary, or the pancreas. If it forms in the pancreas, this usually causes the formation of a gastronoma, which releases gastric acid, again causing an imbalance. Tobacco is a big one. H. pylori, huge. Alcohol, NSAIDs such as ibuprofen and aspirin, smoking, stupid food decisions, and stress. So another three S's over there. Symptoms, so pain, epigastric pain, usually a sort of burning sensation. You could also, upon examination, feel a bit of tenderness in their epigastric region. You'll get bloating, belching, nausea, and vomiting. Now, an important factor to differentiate between a duodenal and a gastric ulcer is how meals affect the pain. So upon having a meal, if the pain decreases, that indicates a duodenal ulcer, and if the pain increases or becomes greater, that indicates a gastric ulcer. Now we have Fat Bob to the left because he is eating a lot, because every time he eats the pain goes away, and we have Skinny Bob to the right because every time he eats it hurts. Now what can make bad turn into very bad? Complications. So bleeding, this is of course a concerning one. This can present as hematemesis or melena, in which case it will show as a sort of ground coffee texture. A duodenal ulcer can cause scarring and strictures, which can lead to an obstruction, pyloric stenosis, again very concerning. And a perforation can also be caused. So if the ulcer keeps just digging through the mucosa of the stomach and all the different layers, the undigested food in the stomach can leak into the peritoneum. The peritoneum is normally a sterile area, so when undigested food gets in there, the body will react accordingly, and it'll just be a disaster, and you'll get peritonitis. Investigations. So endoscopy is usually the go-to investigation. You could also do a biopsy with this to rule out malignancy. Of course, a biopsy may be contraindicated if the person is already showing any sort of severe complications such as bleeding. A rapid urease or a flow test is also something very important to do because it will show you if there's a H. pylori infection or not. Barium swallow. Now, this is one of the investigations you can use. Of course, it's not extremely accurate, but it can indicate if there is an ulcer. Labs. Again, this is really to rule out neoplasias. So if the person has increased serum gastrin, that could indicate a gastronoma. If he has increased serum calcium, that could indicate a parathyroid tumor causing hypercalcemia. Management, the biggest one is lifestyle changes. So diets, and I've crossed out curries because spices can exacerbate the symptoms of an ulcer. Smoking and alcohol, stress, big one. So drugs, of course, I have indicated you should do it right. H2 receptor blockers such as cimetridine, antacids like Gaviscon, and PPIs like omeprazole. PPIs combined with antibiotics is usually the frontline therapy for H. pylori. A good mnemonic to remember the therapies for H. pylori is please make tummy better. So PPIs, metronidazole, tetracycline, and bismuth. If it's extremely severe, it can turn into a surgical intervention situation where you might need to do a gastrectomy or a vasoectomy. Essentially, what you're trying to do with the management is find the underlying cause of what's actually causing the imbalance and treat that. Everything else is really a band-aid, and it really is a multidisciplinary approach. So if a person has a diet problem, you can ask them to consult a dietitian. If smoking alcohol addiction is an issue, their GP can help with that. I have met people who have went to psychiatrists to deal with their stress for the sole reason that they were having chronic ulcers. So again, it's a big thing that causes ulcers, and eliminating it usually solves or helps the problem. Thank you all so much. Take care.